So we're just missing Sarah then. Sarah. Okay. Right, I make it 6:30, and I think we should just start the meeting. And my apologies that we have no fire alarms to read today. So if anything happens in my house, then you are still safe.
We'll come and pull you out.
Sorry?
We'll come and pull you out.
I hope so. I hope so. Okay, good evening and welcome to this virtual informal meeting of the Adult Services Overview Scrutiny Committee. It was decided to hold this meeting online due to ongoing problems with water facilities at Borough Hall. May I remind the members that as the meeting is being held online and informally, no formal discussion can be made. Okay. Number one, agenda item number one. Question from member of the public and members of the council. We don't have any. Hi, Sarah. Sarah. Yeah. Ashok, you have a question? Sorry, you're on the mute. Ashok, you're on the mute.
Sorry.
Yeah. I'm okay now. Just a question in relation to the last month's council meeting, particularly Councillor Kraft's questioning in terms of integrated care, falls, and what's the relationship between hospital and hospital discharges and the use of the fall detectors. I just wanted to comment because I wanted to consult Health Watch. From other Health Watch, particularly Lancashire, what we have got is that a system is integrated with health. So health integrate, because it's health integrated, it is the telecare as well as telemedicines. Both are combined together and both resources are made together, and they have got a integrated sort of false strategy.
Sorry, sorry, Ashok, to interrupt you. Do you have a question or is just a comment?
So, right. Now, my question was, is it possible for us to explore that kind of thing in Bedford?
And who's this question to? Sorry,
question is,
one of you.
Thank you, Chair, and thank you, Mr. Khandelwal, for asking the question. It is our ambition to be as integrated as much as possible. The current Telecare contract is not an integrated service, unfortunately. It concerns more telecare and doesn't really look into telehealth. NHS has a national digital plan at the moment. There is NHS Digital, which does everything from NHS record to the apps we use and things like pulse oximeter and blood pressure things with absolutely what you're saying. This is something, there are a couple of ICB colleagues who are working in that area, and we do meet regularly. Gulmore and I have been invited to one of the catch-ups to see how we can link up. But the telehealth ambitions are really driven by NHS or ICB colleagues. With the neighbourhood health agenda, we do expect probably further conversations on those lines. But as of now, it's not. But the mission always remains to work as closely as we can with ICB.
And can I just add, because I think you asked about the strategy as well, but there is a very close working strategy between health and social care with our Falls team and the NHS Falls service and the ambulance and paramedics. So that's another good connection for the strategy.
Thank you for that. Ashok, do you have a follow-up question or
No,
you're happy with that?
Thank you, because it makes sense if we have got a joint strategy. It saves
Yes.
money and reaches more people. That's my comment.
Excellent. Thank you very much. Does anybody else has a question? No? Thank you. We move on to agenda item number 2. Agenda item number 2. Do we have any apologies, Lynn? I think we're all here, aren't we? Yeah, good. Excellent. So we move on to agenda item 3, minutes and actions. Due to this meeting being informal, does the committee wish to note the minutes and the action tracker of the meeting held on the 16th of June? The minutes will then be formally adopted as a correct record and signed at the committee's next meeting in September. Is that everybody happy with that? Yeah, sorry, thank you. Okay, that was quick. We move on to agenda item 4. Agenda item number 4, disclosure of local and or disclosable pecuniary interest. I'm sure you're aware of if you do need to declare any interest, please put your hands up and let me know. Thank you. I would also prefer if you could raise your hand in the chat box so I can know who's asking a question and when. So sometime I might miss you. So thank you for that. Right, moving on to agenda. Okay, agenda item 5, Care Quality Commission Assessment, Quality Statement 1, Assessing a Need. Please could I ask the Chief Officer for Practice Quality Standards and Statutory Adult Services, Moranun, to introduce the report. All yours.
Yes, thank you, Chair. What I'm going to do is present the report that was in response to a request made at the last committee to do a deep dive into assessing need. And the introduction of this report in the summary explains how the Care Quality Commission undertook an assessment in every local authority in England of how well the authority carried out its responsibilities under Part 1 of the Care Act. There had not been a national or a nationwide assessment since the Care Act was introduced in 2015. And so it was about time that all authorities were assessed. And we were one of the last authorities in the cycle. But it won't be the last time that the authorities are assessed. So as the result of the assessment, which took place by a very extensive evidence submission, a presentation, and then a 3-day on-site visit, accompanied by visits and meetings with particular voluntary organisations, independent sector providers, and user and carer groups, and also an examination of, we had to submit 50 case files, out of which they chose 10 further examination. So it was very thorough. We received a mark of requires improvement, as you are aware of since the last committee meeting, and we've accepted the findings and have put in place an evolving improvement approach focused on reducing waiting times, improving quality data, strengthening risk oversights and supporting unpaid carers, and providing clearer guidance with an evidence-based focus through an adult social care improvement board. So this report provides an update on the current position and work in progress around assessing need. So if we move on a little bit, the current position is that we do have an improvement board that has been established. There are 2 independent observers or overseers, depending on how you look at it, one from the Department of Health and Social Care and one from the Care and Health Improvement Agency. Both have slightly different roles to one another, but we are expected to show visible improvement within the next 3 months, which is 6 months from the time that our assessment report was received on the 18th of March. This isn't the final time that we will see the CQC. They have started already with follow-up assessments in particular authorities, and we won't know when they will come back to Bedford, but they will come back to Bedford at some point. And so I think that's really important to say, and then we will be able to point out the improvements that we've made and the reports that we've made to the improvement board. We also have an independent chair of the improvement board, and that is also the independent chair of the local safeguarding adults board. At the same time, we're working with Newton Consulting on a transformation plan, Thrive, which was discussed at the last committee meeting, and that focuses on several key areas, and they will assist with the CQC improvement process in relation to assessing need. We have been improving our understanding of the data provided for waiting lists and waiting times, and we've been developing a gap analysis for all data used on a regular basis to better manage our performance, and I've given a little bit more information on that in one of the sections below. We've also got a new data-driven platform called Intelligent Eye, which is in the process of development at the moment across the whole council, but the priorities are adult services and children's services, because at the moment, any investigation of data needs to be done manually. So we get weekly information on a number of different areas of performance. That is headline information, and as I say, anything that we need to look at in more detail has to be done manually. So as of what we need to, in terms of the data-driven platform, we'll be looking at the total number of people waiting for an assessment, for a review, care planning, for occupational therapy assessments and carers assessments. And as of this week, we know that we have 419 people on the waiting list, and the people who are waiting over 28 days is 295. And we know that because we have to look at that manually. In terms of people who are waiting over 3 months and over 6 months, what we have to do is verify our figures with our colleagues in the analytics and information performance team, and we can look at that in a little bit more detail and provide written information on that. And we know that the longest genuine waiting time has been 388 days, which we've done further examination of, and an appointment has been made with that particular individual for next week for their assessment. So we do know this information, but it takes an awful lot of work to get to it, and that is one of the issues that was brought up by CQC in their assessment. In terms of the number of carers, for example, we have the number and percentage of carers who will receive assessment, direct support, direct payments or preventative support. That will also come through Intelligent Eye. But at the moment, we know that Mobilise, our new carers organisation, one of the new carers organisations that works digitally, are reporting a very good uptake of people contacting them and using their app. And we also have a local social worker who is concentrating on carers assessments at this time. So contacting them, seeing if they are still wanting an assessment, and then carrying out an assessment with them. And has also gone through another list on another set of people on the waiting list to see whether they still require a service. We know from further examination that the data quality has been a shortfall. That's not a fault, and it's nobody's to blame. We have a fairly old-fashioned system, which, as I've said before, we are updating with Intelligent Eye. We have a greater scrutiny on data. So in terms of, we have analytics information every week. That is raw data, which I've described. But that is examined closely by at least two of us sat in this room, plus others. And if there are any issues that can be examined and rectified quickly, just as I said about the person who's been waiting 388 days, is immediately examined and picked up so that we know that they were lacking in assessment and they needed that. So there's increased scrutiny by colleagues. And we've also got a waiting well procedure so that we contact people within 6 weeks of them being on an assessment waiting list. However, what we are doing as part of the improvement plan is reducing the time where we contact them to 4 weeks rather than to 6 weeks. So we do have that procedure in place. I don't know whether you perhaps want to, we do have a little bit more information, which is very recent around the occupational therapy ways in this, which Prashant has been working on.
I think one of the questions was what improvement has been made since April. So there have been some significant gains in reducing both the number of people waiting, but more importantly, shortening the length of the wait. One of the areas highlighted was occupational therapy waiting list. So that was a key area of focus. And it's therefore encouraging to see that since April, we have reduced the number of, as in the longest wait, from 165 days to 66 days, which is a reduction of 99 days or 60%. That's a really significant demonstration of what we are trying to implement and do at the moment. We've done that by engaging with teams and explaining what needs to happen and when it needs to happen. Also for occupational therapy, we've taken time to probably look at the waiting list and see what can be dealt by a registered worker and what can be dealt by an unregistered worker. So there is clear areas that we have looked at. And we are hoping that this figure will go down even further. But 66 days is a significant improvement as compared to where we were. So that's something we're going to plan to do in all teams, but just an example of where we are in terms of progress made since April.
Thank you, Prashant. So moving on a wee bit into the detail, there is a summary on what the CQC assessment reported, and I've already picked up some of the issues around that, such as people and unpaid carers sometimes experiencing delays in receiving assessments, care planning and reviews, while putting in place a digital offer through Mobilise, and also the new carers organisation, which is reporting a lot of people picking up those services. And then looking at feedback being variable. Well, one of the things that we will be looking at with our carers organisation is a more robust form of feedback, so that it's based on fact as well as on opinion, and looking when we're developing the carers strategy, taking that out to organisations and getting a lot more detail. So it's co-produced, and the deadline that we've set for that is Christmas. But in terms of context, I think it's really important for us to be able to talk about throughput in adult services. So in the 12 months between May 2025 and April 2026, there were 3,067 referrals into adult services, an average of 255 per month. And that does not include safeguarding. There was a separate list for safeguarding. So it increased to 304 in May 2026. So, you know, it's the average, but sometimes it's higher, sometimes it's lower. Assessments completed within 28 days of the first contact did range between 41.1% in November 2025 and 55% in August 25. And that had increased to 57.1% in May 2026. The target for this is 65%. So what we want to do is make sure that we keep on with the steady improvement that we've shown over the last 12 months, and make sure that we reach the target as soon as we possibly can. However, there are some things around those targets that we have locally. They're no longer national targets for that timeliness of assessment within 28 days. And because it's no longer a national target, it doesn't have a national definition. We've been very, very strict about the way that we make our definitions, and yet neighbouring authorities they'll say, well, 28 days to complete your assessment from the time it is allocated. What we use is 28 days from the time they first make contact, which is the very old-fashioned definition, which most authorities are unable to keep. And I've already talked about the reported figure for the longest wait is dependent on a weakness within the client information system and on recording. So if a case has been left open due to a potential return of the person coming back, they might come back 2 years later, but what we've been counting is the time when they first made contact 2 years ago. And so we've been doing a lot of work about cleansing that information over time, so that we count from the most recent time rather than the very first time that they made contact. So we accept that there were anomalies in the waiting times at the time of assessment, and we know that waits ranged from 1,000 days to 300 days at their longest. And as I said earlier, we pick those things up as soon as we can see them. Is it a data cleansing issue, or has somebody really been waiting for too long? The other piece of work that we have started and that we will be continuing with our Intelligent Eye and using other methods is stratifying the waiting list in relation to the type of referrals received, including first-time referrals, repeat referrals, referrals for or from people who are already receiving a service, and from or about carers as well. And along with waiting times, this is helping us to prioritise areas of further work, as I've just described earlier, around the locum, who is concentrating very much in the next couple of weeks on carers assessments. So moving on a little bit, it's not just about numbers. You could throughput everybody as quick as you like. You could have nobody on the waiting list and everybody's getting a really poor service. So we also have to think about qualitative work in relation to assessing need. And there are a couple of really big pieces of work that we have continued to do on this. For the past 3 years, we have been doing case file audits. We had a break while we made the final preparations for CQC, and then the time that it took to respond to them and so on. And we've started those case file audits again. Everybody from the director down to up to 30. So we do about 30 a month case file audits. So in the space of a year, you can have up to 10% of all cases have been case file audited. And that goes through to supervision sessions, is brought up in team meetings. We get a monthly analysis of that. And from there, we can see where our gaps are in recording. Are we making the best use of the recording that we have? And what we have noticed as auditors since the case file audits began is a real improvement in the standard of recording by practitioners. And Magic Notes is not in its exact infancy, but we'll see how Magic Notes also affects the way that we make records in the case files. In addition, we have a quality assurance governance group, which sounds very grand. And that is a way of all team managers work together in order to accept any case that is coming forward for funding or for changes in their need. And that meets twice a week. And again, I think it's the best way of assessing quality in an immediate sense. Because if you have to say, I don't understand why you're asking for the service you're asking for, then you can send it back to the practitioner who needs to do further work. Most of the time, however, that doesn't happen, but it does mean that all managers from different services get a good idea of the type of work that is being done throughout every part of the service. And it's a very another immediate way of assessing the quality of the work that is being done. I think it's also important to point out around assessing need that there was no criticism of the quality of the assessments by staff by CQC, and the assessment highlighted and the strengths-based practice that it has been embedded into the work of the directorate and reinforced by those qualitative methods. The big challenge that we have, and which I think most authorities have, is to retain that quality while making sure that we do the throughput is quicker. And one of the issues for us in data quality is understanding how many new cases come in a week with how many go out per week, because that is the way that you reduce the waiting list. Prashant has given a really good explanation of how that's been done in occupational therapy. In terms of the throughput, just to describe what has happened in direct payments, for example, as you know, we've been a very, very low uptake of direct payments for several years. That is now starting to increase. But what we do know is for every person that leaves direct payments, another one comes in. You need to retain that number, but also increase it in order to bring your numbers up. So last year, we know that there were 81 people who left. They either died or went into residential care for the most part, and 81 people came in, plus another several, in order to increase the numbers. So that's on a small scale. We know it can be done on a small scale. What we need to be able to do, and we'll do it with the help of Intelligent Eye, is do that across the board. I think the final thing to say is that every authority, wouldn't matter if we got 90%, we would still have an improvement board, we would still have an improvement plan. And there may well be issues about assessing need as a quality statement in every authority. It is not just particular to Bedford. But we're very lucky in that we've got the improvement plan. We've also got the Thrive programme. We've got Intelligent Eye. We bring in all of those things together in order to make sure that we make the most of the opportunity to improve the way in which we work and maintain the good service actually that is given to the people of Bedford. So I think that's everything from me. Thank you, Chair.
Thank you so much for such a detailed report, and I'm sure it's quite a lot to take as a committee members to remember everything. Okay, I have Councillor Rahman already put up hand for a question. Councillor Rahman, go ahead.
Thank you, Chair. I think I've got few questions. If that's okay, if not, I'll just shorten it. Thank you for the report. One question is, sorry, I can't see properly, so bear with me while I try to read it out to you. The CQ waiting list and protecting vulnerable residents. The CQC identifies concerns about delays in assessments, reviews and care planning, and the report refers to significant waiting times. Can officers provide the committee with the current position waiting list? I think some of them might have been already answered, including how many people are waiting for assessment or review, how many are waiting beyond agreed timescales, and what assurance can you give that people on the with the highest level of risks are being prioritized and supported while they wait? I know part of it has been already answered in your report.
But thank you very much for highlighting this, because what I should have said and should have included is that every single person is triaged when they come through. So those 3,000 people that I referred to in the space of a year, every single one of them will have been triaged before they go on to wait for an assessment. And the people who are deemed as the highest risk will wait the least amount of time. So when I was looking at the longest wait for this week, the shortest wait is 3 days. So people do not wait very long if their risk is assessed as very high.
Thank you. Councillor Rahman, do you have follow-up? Then Councillor
I have got two more questions, two short ones. Can I ask them together, please? Data accuracy and performance assurance. The report acknowledges weaknesses in data quality, including recorded waiting times that appear to be as long as 1,000 days due to system and recording issues. What assurance can officers provide that the performance information now reported to members is accurate, reliable, and reflects the real experience of residents using adult social care? And if I can ask the other question as well, please. Thrive program. The report refers several times to the Thrive transformation program. Could officers also explain in practical terms what difference Thrive will make to residents who rely on adult social care and what improvements have already been delivered? Thank you.
So I'll answer the Thrive question first, then, Councillor.
Yeah.
There's a number of different work streams, and many of them got to come to full fruition because they do take some time to develop. One of the things that we're very excited about is the work at the front door, is changing the way in which we work at the front door so that we can streamline people through much more quickly. And instead of we may triage and then they wait for an assessment. If we can solve the issue at the very first phone call, that is what we will be doing. And so then they're not joining another waiting list, or they receive their advice, their information, their signposting, and then they'd be called back at a later date to find out how that went on for them and have their needs changed since that point. So we have a whole process in place, and that is due to be launched in September. We're doing all of the groundwork for it now. And that's likewise in our safeguarding as well around assessing need. Everybody is triaged, and we're looking at the way in which we work to make sure that people can go through the process as quickly as possible. And then
just in terms of longest wait, because it was in the CQC report and the anomalies in the data, as Maura has said, and I think Prashant alluded to, we have seen and CQC picked up when we had to report based on what the system was telling us at the time, that we were very confident, but we could prove because of a system error that somebody wasn't waiting 2,000 and something days. And CQC accepted when we went back into the case, it wasn't an accurate reflection. However, what we do have and what we have put in place, because we found out, and Maura's just explained in the report, that really, if somebody made contact a few years ago, had a service in place and then recontacted us, what the system was doing was adding on all of those days in between, and the person had a service, had an assessment, but they were being classed under the system as waiting. So the longest wait is a big focus of the work, and I'm sure Prashant and Maura will be able to talk about this more, but every week since then, since we've picked up on that, we have a report, and some of those we had to work backwards in time to see what is happening with the system to allow this to happen. We want to get to a position where practitioners can't fall back on that, but the system allows it to happen. So the weekly reporting is a really good assurance. And Prashant, I don't know if you want to talk about how that's being targeted in teams.
Thank you, Dr. Raman. Hopefully you'll feel better soon, and it's good. I think, like it's been alluded to, I'll just give you a simple example, if that's okay with you. What we tend to do is on Monday morning is when we get the reports. There'll be at least 3 sets of eyes looking at that hour, 2 hours. And if there is any human errors, for example, the example given is Mrs. Smith, who we saw in 2 years back, and another contact comes in for her. She's been long closed. The system sometimes picks that from the initial contact. So as soon as we see that, we will go to the person and say, there is an error, we need to do something about it. There is also still ongoing sort of things with PFA, which is preparing for adulthood in terms of transition. In that sense, we don't want to close the case because we get a referral for a young child when they're 16 in preparation for when they'll be 18. And we want to engage with the children's services, but they're not on our waiting list as such, because till they become 18, we have a handover process and we are preparing things for their 18th birthday, so to say. And that detail is being worked out. And we are very, so there is at least 3 people whose Monday mornings are dedicated to looking at that, if there is any anomalies, because a longest wait should have a linear pattern, isn't it? If today, 1st of January, let's say there is 300 days, which is the longest wait, next week should be 307 and 314, etc. So what we look for is those anomalies. Suddenly, if there is a spike, why is there a spike? Till we get a system which is Intelligent Eye in place, we'll have to do it manually.
A really, really good area, though, I think, to show is that the eyes that are on that on a Monday have shown that there is change that's possible with our practice and our practitioners to avoid that from happening in the first place. But where we started to see the anomaly that came through in the CQC report, we no longer have those levels of weights. They have reduced, and I'm not sure if you have put it in here, Maura, but we've certainly got the latest. It's way down. It's not like that. And we can see straight away which team, which service, and as Prashant's already demonstrated, can go back to the team and down to the worker level to rectify the error, so we don't end up in that position. When we have the Intelligent Eye, and we're not looking retrospectively on data that's coming through a system, we're looking proactively on a dashboard, we'll know more instinctively. But at the moment, we're not in that position and we're having to work manually, as Maura says.
Thank you very much, Councillor Rahman, for your questions, and I'm sure you got a good answer back. Councillor Crofts, you're next.
Yeah, hi. I've got quite a series of questions, but this is on the basis of how this committee can help the Directorate with meeting the requirements of the CQC. I just want to start with language, really, because we've been told that everybody, whatever rating we got in assessing needs, would get a letter regarding the requirements of an assessment. But looking at the CQC published report for other local authorities, which only came out today, we are the only area in BLMK that got an A requires improvement. Luton, Central Beds and MK got a good rating from the CQC. And we as a council got a requires improvement. So we are the only council in BLMK that got a requires improvement. Also, because we're discussing assessing needs tonight, there was only 6% of 143 local authorities that scored an inadequate on assessing needs. And we were one of those 6%. So the language around it doesn't matter whether we do 70%, 80% or 90% assessing needs or doing reviews would be irrelevant. I think it is relevant, because the main finding of the CQC was that people were waiting too long to have their care reviews. And over 70% of people, when they came in November of last year, were waiting more than 28 days. And that's what the CQC report says. Now, to try to start to understand why in November 25, 70% were waiting more than 28 days, I refer back to the minutes of the previous meeting, Chair, and we did ask for a staffing report to say how many staff have we got that are doing these care reviews? Is the target of 65% enough? Who sets that? We now know there aren't any national targets for that, so that must have been locally set. And thirdly, we know that 2 additional social workers have been recruited to reduce the waiting lists in terms of locum social workers. But again, one of the findings of the CQC report was we're lacking data as a council. And I still think this committee is lacking data. This report we've received tonight has got no data in it. It's got no, our waiting list might be improved, but we haven't got the data. So my first question from all of that is, well, 2 parts really. We have a system called Liquid Logic that we use to register care within the council. what does Liquid Logic give us in terms of waiting lists and who's waiting, how long they've been waiting for? Or do we have to produce that manually on a spreadsheet, which has been mentioned in reports? And secondly, the new system, Intelligent Eye, do we have a timetable for that of when that is coming in? So we will have the data, because at the moment, I don't know, and I am confused. So that's my first two part of a question.
Shall I just talk
Yeah.
about Intelligent Eye and come back on? Intelligent Eye is a platform to pull information once it has been cleansed through the Liquid Logic system. So the work that's going on at the moment, and we are receiving reports, and they are from the system against each case. The work that is going on before Intelligent Eye is ready, is to make sure that the data is cleansed. Because what we have got is people that could be waiting at the front door, but are also referred in for assessment for it could be OT, and they could be added in twice to the data. The cleansing work that's going on that we must get right, which is happening, will make sure that before we have the data more up to date with Intelligent Eye that draws from Liquid Logic and you know, across the council in other systems, that it will be accurate, because the cleansing and the work is in place to make sure that happens. So that the programme of that is going on at the moment behind the scenes before we can do the work, because the compatibility of Intelligent Eye with Liquid Logic is a big part of that process. So in terms of the data that we've got, adult services, children's services and all others at the moment are reliant on our performance intelligence team, who pull the data from Liquid Logic, and then we have to work on that more manually, but it's coming straight from the system. But there are some system areas that we are working through a change control group in adult services to make sure if there's a fix in the system that needs to happen, we have a lead linking in with Liquid Logic. We are working, some of the anomalies that we have in Bedford are happening in other places, and the discussions with our partners in other local authorities are similar to ours. They didn't get requires improvement, that's true. Some of the feedback was different, such as the safeguarding weights, and the teams and services are different. And our performance setup in Bedford is different to the other local authorities. It's not like for like. There are lots of teams and systems. Other services had whole teams of people preparing for CQC. We didn't have teams of people. We're working. So all of the data and the information it is comparable to the size of authority and the systems and processes in place. So we have got, as Maura has described, some of the work that's going on, and indeed through those Section 50 areas where we have got work continuing, we will be showing the data and the evidence through that, and that's being worked on at the moment. If we were to give it to the committee now, we can give you the headlines, and that's why we couldn't do a deep dive, because we're on the journey. We can continue to give the updates on the data, and the assurance isn't, in fact, at this moment in time to the CQC, it's the Department of Health and Social Care via the Improvement Advisor. And that's the work we're doing through the board. So the chair of this committee, the portfolio holder, a number of independent chair, the Improvement Advisors have to be assured, as well as us assuring the committee on our journey. And what they don't want to see, and what they've advised, is a quick win where we've just cleansed the data. We've got to be thorough and sure, which is why we're taking the staged approach. If we just fix something really quickly, it's likely to look as if there wasn't a problem in the beginning. And we know that there was some issues with the anomalies. We have discussed with other authorities who've got similar system, but they probably had a team that were able to do some of that cleansing before CQC came in, and we weren't. We weren't in that position. The raw data was the raw data. The capacity, not just in adult social care, in the council, didn't allow for that work to happen. So we're working really collectively, and we need data. CQC are very familiar with, as they're working with lots of authorities, with data dashboards that are more live than looking back retrospectively. But we're having to look back and then work on the raw data whilst we await for intelligent eye. Some of the things we've seen and how we can show it in the future are really remarkable. And already through the Thrive programme, we're seeing where our practitioners can look at data, can understand their position in this and how it links to practice. Maura might want to add more on that, and Prashant.
No, I think that you've done a very comprehensive response in terms of the data. We can only present the information that we have. And we've already explained that we do get analytic reports every Monday morning. They are examined in fairly close detail. We don't rely on manual spreadsheets that practitioners put together by themselves, which may or may not be accurate. Those days are long gone. So the information that we get it does come from liquid logic, and we've explained about how anomalies can arise, but also some of the gaps in data, which we've explained around reviews, for example, or people who are on the waiting list. What are they waiting for? Is it a carers assessment? Is it are they new that we've never met them before? Are they waiting for something else? Are they just ringing to tell us something? So that is all bundled together in that 3,000 cases that come through every year. And I think the director has pointed out, in terms of capacity, it's important for us to remember as officers, nobody wants to be told that they are inadequate. Nobody wants to be told that they require improvement when they know their neighbours who don't provide a better service than we do to the individual. They've got a higher score from CQC. Nobody wants that outcome. But what we have to also accept is that the requirements of Bedford are the same as the requirements of a big county with plenty more people to prepare for CQC assessments and inspections, and who can have the resources to take people off their day-to-day work and make sure that that is all that they are doing, is doing that preparation. And I think we have to remember, again, as officers, that for the past 12 months prior to us receiving the outcome, we were one person down. We were depleted in terms of the resources that we did have. So we had even less than we would expect, and in terms of preparing for the CQC.
Can I just come back, Councillor Crofts, on the query about reviews and assessments, because it's a really important point. So in the anomalies as well, and this is the work that's going on to cleanse the data, if you've had a review, you're not waiting for an assessment, but some of the anomalies are showing the same person as waiting for. So if you've had a review or you've had an assessment, you have been seen, but you could be sitting on another list on the system. So some of our data, CQC were right to point it out. We couldn't show them otherwise. We will be able to when we have completed the big piece of work that's going on. And the link with the Thrive programme and those areas of work to do with reviews is a big part of it. So the review work that's going on and the front door work and how we're getting to people earlier will help our recording, our practice, and the data with intelligent eye. So already some of the work that's going on day to day that actually is really, really helping. It won't be a huge help immediately, but if we think about reablement, there might be people that historically, because of our setup with reablement being more towards hospital discharge, would be perhaps waiting through a system in the NHS, but they didn't come to the local authority. Now we're turning those people through our front door under the Thrive programme, so they don't have to have a full Care Act assessment, because a reablement assessment can get them back on their feet sooner. So those waits, we're already seeing things turning and changing, and we will be able to show it in the data much more as it progresses, and we will show it through the Thrive programme, which is part of our transformation, even though it's not directly related to CQC, because what we are working with and what we've been providing updates on and is part of our plan in Bedford, we are dealing with the most major transformation programme ever at the same time as the CQC programme, and they do link together in parts, because for our practitioners and for people receiving services, it's really important we get this right from the start. So whilst it is disappointing, and whilst many comparators are taking place with our neighbouring authorities, we are able to go back and see why there were differences. And some of the differences we are seeing is not about the way we're doing, and not about the outcomes for people, which we take very seriously if they were genuinely true, and some will be waiting, and we do have a waiting well. Our neighbouring authorities, for example, didn't say 6 weeks that they went back to people, or that they went to such lengths. So in the occupational therapy area, people that were waiting for major adaptations, the bit that doesn't show, but is a reassurance, I hope, to the board, and we will share this as we normally would on the programme here in this committee, is around what we do in the interim. So where people have made contact with us and they might be waiting, as the triage has taken place, they have had a response. They do have information to say what to do if, and how to raise through our contact team if a matter becomes urgent. And the same in the occupational therapy, with what we can do in the interim while people are waiting for the major adaptation work, which is the next part of the assessment programme. So there's lots of factors at play here. You could, at the moment, because of how the system we're finding, which is actually really helpful to us before we do move into Intelligent Eye, if we can see that some same person has had a review, but they're down for an assessment, or the other way around, they're not waiting, but they're classed on the system. That's the cleansing work.
I think it's worth mentioning about the 28 days assessment as well, which was it has to be put in context, because Bedford measures that from the first contact was made, whereas other authorities, and there are a few, who measure it from the day it was allocated. So there is a difference in how we're measuring things.
Big difference.
And I'm sure we will say that. Also, we have about 480, how many?
419.
419 residents waiting for services. If you put it in context that we get about 255 referrals requests a month, that's less than 2 months. So there is progress being made in terms of numbers. I understand that we can provide probably more data, but that is a significant piece of work.
I'm confident with some of the information that we are working on now that will reassure the committee more when we've been able to work further on it in preparation for our next steps. But we are now identifying where some of those areas are, what's genuine and what is duplication and what's an anomaly. That is part of the work. That's why if we rush, we're just answering the wrong questions, because we're just churning more incorrect anomalies that could present us with a further problem down the line. We want to prevent that from happening and getting it right. So there's an awful lot of work going on from the performance information that is coming on a regular basis, and how we're checking back. But the other thing I think that you mentioned there, and that is around the spreadsheets, and I think it was a point that was made in the CQC report. There weren't any actual spreadsheets that weren't part of the data, but the area that they picked up on was a comment from our safeguarding team about themes. Not that the systems weren't, the people had been entered onto the system correctly, but the themes of safeguarding was a manual. Not that they're not kept on the system at all, but that was the point. We've traced that back. We've spoken to CQC about it. It's factually correct. They did find that, but it isn't correct to say that it wasn't being monitored through the system, because every case was on the system. And that's the bit that we're ensuring, and through the improvement board and all of the work that we will share with the committee as we develop, is the stuff that we don't want to be in the same position again. We want to be really forewarned and for the outcomes for people really, really clear that if they're waiting, it's a genuine wait, and what we're doing to support them during that waiting period. And we were criticised for the 6-week period on waiting well. We've reduced it to 4, but we do also have that proviso that people can contact. And we do see people regularly that said, I made contacts on this date, my situation's changed, and somebody through our first contact will go out maybe and see somebody, or they will have a different discussion because their situation has changed. There's lots of variations to what is considered as waiting, but that point about review and assessment is an important one, because you don't require a review if you just had an assessment. There is a period of time where the review would be put in, and I think the way in which we count those reviews is really quite critical, and there isn't a national target for it. We did set our own, and some of the work around the reviews and the reassessment is part of our targeted area, along with Thrive and all of the other areas as well.
Councillor Croft, I believe you got another question.
Yeah, thank you for that response. I mean, it is acknowledged in the CQC report that when we do the reviews, we do them really well. Okay,
Yes,
so we will
yeah.
say that. So there isn't a problem with the way that we as a council do the reviews, because it was noticed by the CQC that they are strength based. There is specialist expertise within the team, and people get timely advocacy and support basically when reviews are actually being done. So this is just about, again, the data. And I appreciate we might not have the data this evening, but the KPIs for Q1 of this year, when will they be available? That'll be for April, May and June.
We have to rely on our colleagues in the analytics and information performance team for that, and for that. And then
Okay,
that
so
information is made available to by the chief executive, both for priority indicators and to elected members.
okay,
And I
so we
think
can so we can ask for that data. That's fine. So in relation to the improvement plan, which said by the end of October, our waiting lists with the 2 locums would be addressed.
Yeah.
Is that October target date still on track?
Yes, it is. I'm really pleased to say that it's on track. We've got 1 locum, as I described when I presented the report, in our the contact team, and is working on targeted pieces of work, as I described, certainly with carers assessments, for example, where we've done some stratification. And we have another very experienced locum working on the safeguarding team on what is called the medium tray. So working his way through those. And so we are confident. They're both very, very good. And because they don't have other distractions, they're getting on with that work. It's really targeted. They're given a list. I personally meet with them every week to find out how things are going, and also to get feedback into our regular teams about how are the things we could be doing differently, and that can enhance some of the practice. So we are confident that yes, if they are here in October, then those targets will have been met by October.
And just the other assurance around that, they're not, although that's targeted work, the work across the rest of the teams is still going on. So it's not just down to those 2 workers. Our teams and services are doing the reviews, and our Thrive programme is linked to the reviews, and the assessment work continues, and the work at the front door to support people so they're not waiting is part of the transformation programme. So it isn't just down to 2 workers doing all of that work.
Waiting list, no.
It's a bigger programme.
Do you think the data cleansing will be finished by October?
Oh, I hope so. Yes, we are assured that Intelligent Eye will be moving quite quickly through the different work streams. There's a series of work streams. We're very lucky that we have the Liquid Logic practitioner, and I met with herself and the principal social worker earlier. I've asked that both of them are in every single work stream so that we can make sure that there is the technical expertise as well as the practice expertise to make sure of consistency throughout that programme.
Okay, great. I've got some questions on carers, Chair, but if anybody wants to answer questions before that, then I'm free to others to have questions answered.
Thank you for that. I believe Councillor Rigby had some.
Well, thank you very much.
Okay.
Thank you, Dean, for that. Yeah, I'm really pleased that, you know, the waiting times seem to be we're really getting to the bottom of them now, and it's most gratifying to know that we are there. Someone's putting the show on the eyes and move the computer around. Yeah, okay, so the data quality. The report identifies historic weaknesses in the waiting list data. How confident are we now that members are receiving accurate and reliable performance information? And obviously we're talking to the Department of Health and Social Care. Have they accepted our improvements so far?
I can't say on the conclusion of the improvement, but the journey, just so that you know how there is a board, which I know you're all aware of, there is also monthly supervision individually with myself, with each independent improvement advisor, and then together. And the independent chair of the board is linking in. So the feedback I'm receiving is that slow and steady is better than tick box, get it done, because we are transforming our services. And what we've been advised is we want to make progress, steady progress, and we want to be able to provide that assurance on that it's sustainable and that we operate differently when we transform, because every local authority has this challenge. We don't just want to clear a waiting list and then be in the same position again.
What we know,
Yeah,
of, and I don't know this to be the case with our local neighbours, but there are authorities around the country that brought in whole teams of people to clear their waiting lists before CQC arrived, and that we do know that in some of those cases the waiting lists are creeping up again. So it's the equivalent of they've loosened their corsets now that the CQC is on. We have played with, to use a cricketing analogy, a straight bat all the way through. And I think that we have been very, very honest and open about our position and about the way that in which we have worked. And that has not done us any favours, but it did show that we do know ourselves. We didn't try and hide anything, cover anything up in terms of the information. And now that we have the improvement advisors, I think that's very much going in our favour, because we don't have to go, oh, well, in terms of any of the explanations. They know exactly where we're coming from. So to date, we haven't had any indication that they are disapproving of what we do.
No, so the report that went to the Department of Health and Social Care is actually a verbal update from myself and observation from an independent advisor, and it's their report. It's not in the public domain. It's a feedback on our progress. The first feedback discussion was very promising on the work that had already taken place, and there'll be another one in September time, and there will be regular discussions. And the feedback, we had a board yesterday, the feedback is they can see that progress in these areas are being made, and that we are pulling the systems and processes together to be able to demonstrate and work with our frontline practitioners and our partners. So East London Foundation Trust are part of that work as well. But they're not just listening to what we say. We are in the first board, we didn't have the evidence. Second board, we've given some evidence, but we've got further to go because we need the systems and processes to be in place to support that. So one of the improvement advisors is able to bring in additional supports through Partners in Care and Health, for example, around best practice and examples from other authorities where they've tackled a similar problem, and that's areas of work. So safeguarding, for example, there isn't an issue about people being unsafe, but the data quality issue is something we're having to show. at the same time as changing and transforming the way we look at our conversion rates. So one of the things on safeguarding, for example, which isn't the same as assessing need, but came up in the data anomaly area, was really around, do we have, well, we will have an independent audit. It won't just be down to us reassuring. We'll have an independent audit commission that will come in and look back at the audit we had in 2023, check on all of those areas and our progress and our design changes that we're going through at the moment. So it will be very, very thorough, and it already is. So the feedback I'm getting at the moment is positive. You're on the right track. How can we support you to be able to demonstrate? Because they're not saying we're any different to another area. They are saying we're very unfortunate that our data and some of those anomalies, that's not to say people aren't waiting. We aren't shying away and saying, and no local authority can say that people aren't waiting. I think there's one in the country that doesn't have anybody waiting. And that's another matter, because I don't think I can comment on that. Oh, yeah, I suppose really, but that wasn't to do with CQC.
Yes.
We had a visit which was planned, nothing to do with the CQC, and it just coincided with following the Department of Health and Social Care work. So we had a team from the Department of Health and Social Care that had been part of the adult social care attorney.
There's Mark Brown and Charlie Brown.
Yes, sorry. The Deputy Director for Improvement in the Department of Health and Social Care spent the day with us actually in May. And all of our teams, they visited the carers organisation, and as a follow-up to that, some of the Department of Health and Social Care links who link with the Improvement Advisor are very interested in some of the work that's going on in Bedford and took a keen interest in some of the work that is happening. And we receive positive feedback. So there is a connection through, but our test is how we move away from the Section 50 areas so we can focus on all areas of improvement that we need to make. And there's loads going on in that area. But the Section 50 focus and the feedback so far is it's steady and surely, and we have to, there's no way we want to present a glossy picture and then have a CQC visit and it's not in the place we need it to be. We want it to be right from the start, but we do need to make sustained progress. So that we are in that space now where we have some additional resource, and but the big change process that's going on is the sustainability to make sure that we can manage within the resource envelope we have. It isn't necessarily just down to if we employ another 10 social workers, situation will improve, because we need to manage things differently, which is part of our transformation journey, to offer some different options to people at that front door, which weren't available before, and we're working in a different way already around that.
Thank you. Councillor Rigby, second question.
Thank you, Craig. That's most reassuring what you're telling me there. If I've got another question here, it's about managing risk while people wait. I'm asking these questions because I have to satisfy myself that what we're doing is right. How are we assuring ourselves that people waiting the longest for assessments are regularly reviewed, that any deterioration in their circumstances is identified and acted upon quickly?
As I explained earlier, Councillor Rigby, every person who calls the authority is triaged, like you would if you went into A&E, for example. You're triaged and your risk is assessed. And the people with the highest risk are seen the first. Now, that can mean with people who have the lowest risk, they keep getting pushed down to the list, down the waiting list. So we do make sure that we keep in contact with them. They are reassured that if their circumstances change, they are to ring us straight away, and then their risk is assessed again. So that's the reassurance that we have, and that we can also give to individuals and families, that if their circumstances change, they are to ring us again, if they think, oh, I haven't heard anything for a while, they can ring us again. And also we explained before about the waiting well procedure, where we will contact people again. And then, as we've already explained about examining the waiting list on a weekly basis, the person or the people with the longest waits are highlighted, and we go into Liquid Logic, we see who are they, what are they waiting for, what's the contact details, and then to make sure that actually we reassure ourselves and reassure them as well if needed that they're not at any risk.
Just to add, because that is a really big turnaround for us. And when Maura and Prashant have said 3 people are looking at it, we all get this early in the morning, this Monday morning list. Sometimes I'll contact Maura or somebody else, and they'll say, we already know it's not a genuine. We know what the case is. The worker has already amended the system, and we're reassured.
Or sometimes it is
they
genuine.
are, and we know why and what we're doing.
And this is what we're doing about it.
This is what we're doing. So there is fail-safes that perhaps weren't there before the issue around the anomaly was better understood. I think we've developed systems and processes, and now our practitioners, and I think Prashant's example is showing that rather than us say the list is showing this, we've got people being proactive, preventing that from coming on the list in the first place.
Councillor Rigby?
Yeah, thank you very much. And just finally, the unpaid carers, Dean did touch on this. The Care Quality Commission identified unpaid carers as an area requiring improvement. What evidence do we now have that carers are receiving more timely assessments and better support than they were at the time of the inspection?
Yeah, as we said earlier, we do have, in terms of the waiting list, one of our locum social workers, who's a very experienced social worker, is concentrating on the carers assessments. So making sure that the waiting list for carers is coming down. One of the other things is the new carers organisation, Blue Sky, and also Mobilise are now operational, and are making sure that they are working with carers locally, and that really helps as well. And then we have the development of the carers strategy, which will be taking out to carers in the autumn to make sure that it's not just about what I say, it's what carers say is what their needs are going forward and for the future. So we know that they're receiving more timely assessments. We know that there is support that is going on for carers, and we are raising the profile of carers within the directorate. And I think that's evidenced by the amount of self-directed support that carers received is over 90%. And the carers, the uptake of direct payment for carers is way into the 70%. I think the latest, I can't remember, I don't want to be hostage to fortune and say it's 75%. It's somewhere between 72 and 75% of all carers receiving the service from adult services are doing so via a direct payment. So I think that's the evidence that shows us.
Just to add to what Maura said, just for context, when we got inspected by CQC, we were in the process of changing providers, as you know.
Oh, yes.
Councillor Rigby. So there is 2 elements to your question, which is about the targets and how we're doing that. But the more important thing is, do residents who identify themselves or don't identify themselves as care feel supported? And I think that's where we really have done better than we did last year in terms of Mobilise, which is a 24/7 offer. So I think one of the key things that we're finding is that often people have caring responsibility but don't identify themselves as carers. And that sort of support that we don't know but is there. So not every carer will be known to us, but they have support on offer. because, you know, I might be taking care of my son and I'm saying that's just what a father does, not thinking that I'm a carer. But I think in those sort of, there are ways the support on offer for Bedford residents is better because we've got two providers doing completely different things.
The other thing that I think is really, really good, just to add to that, is around the work on the case file audits that Maura spoke about. That's the other area where we can actually see, all of us take part in the monthly audits. We are checking and we can see, I've just completed one a couple of weeks ago before my leave, and I could see straight away that the carer has been offered an assessment in their own right, because one of the things in the CQC report was sometimes carers do say, can you assess me and my son or daughter or my mother or father at the same time? So the option on the case file audit is another mechanism to help us monitor the support to carers and the feedback as well.
Thank you, Councillor Rigby. Before I go to Councillor Crofts, has any other councillors got any question? No? Councillor Croft, carry on.
Yeah, thank you, Chair.
Just-
Just about unpaid carers. I think we have it on our work programme to invite Blue Sky to our committee as the new provider for unpaid carers and carers in our borough. Can I just confirm the process? When an unpaid carer contacts the council, is it the council itself that does the unpaid carers assessment? I know it's a self-assessment as well, or is it Blue Sky?
It's us.
Okay.
Sorry, Maura, do you want to talk? Because there's two areas. We can refer people and people can go directly to Blue Sky if they want the in-person and the community area. We also have Mobilise, which is hugely popular, and you will see when we get that it's not just Blue Sky carers we should be inviting. The two complement each other. There isn't a wrong front door for Mobilise or the carers organisation, but what they provide is the practical advice and support. What we do, and it is our statutory responsibility, is to offer carers an avenue for their assessment in their own right and to identify if they have any needs as a carer. And that isn't passported to our carer organisations. But some of the areas that was mentioned in the report that we are working very closely with the provider on is around the contingency and
just in case plan. Because who can understand contingency? What's your contingency plan?
Yeah.
But we can all understand, well, just in case something happens to you. So that is one of the areas that we've identified and that is in the improvement plan.
Yeah.
For carers.
And some carers do not want a local authority assessment, but they're offered it. But we're able to see that they've been offered that through the case file audit, because many carers just, they know where you are if they want that, but they want something more informal. And the digital approach, and I don't want to spoil the update to the committee, but so far, and we are in the early days, we're seeing that the digital response to carers is offering a service to people who perhaps wouldn't have come forward and identified themselves as a carer in the past. They're often people of working age that are working and caring and are up late at night and are finding support through other avenues, not necessarily saying they're a carer for a long time, but the interaction, which is also face-to-face with a person, not just a load of resources, can link in to the supports available through the Blue Sky. What's really positive, and that's why I think it's really important when the committee has this on the agenda, and certainly operationally and with our practitioners, it's been brilliant to see those two organisations working together and complementing so that the offer is wider than it was before. But their responsibility is different to the local authority offer of assessment, which is to a carer under the Care Act.
Okay, super. Thanks for that clarification, because that's answered most of my questions on that for now. But I think it's really important, Chair, that we bring back carers and unpaid carers back to this OSC as a single item, so we can have a look and deep dive on that as well.
Sure. I absolutely agree with you, and I've got, if no, anybody else got any question? No, I've just got one or two questions. I know we've, looking at the time, you know, I'm conscious of the time as well. I'll just ask one or two questions if that's okay with yourselves. In the report mentions only 2 locum social workers. Is employing 2 locums enough to reduce waiting time list across Bedford Borough?
Well, I think what we've said already is that those 2 locums that we have taken on are concentrated in 2 very specific areas. You could have 100 more social workers and you'd never get through all of the work that is needed. But with these 2 particular, they are working in 2 very, very specific areas, as I said. One concentrating on highlighted areas at the front door, looking at the backlog. They're not working as a member of the team, taking the new cases. They're looking at the old and the backlog cases, and in particular at this stage, carers. We think that list will be, they'll be finished that piece of work very shortly, and then they'll move on to another piece of work at the front door. And then their colleagues, social worker, is working on a very particular area in the safeguarding waiting list. And again, not taking in the new live cases, but looking at the ones that have been on the waiting list for quite some time and following up those investigations.
Thank you for that. I'm sure you have mostly covered a lot of questions in your answers. Just a quick one. Current vacancy rate and agency staff numbers, staff turnover, sickness levels. Is that something you might have some figures on that? Can you give us some rough figures?
It's not something we're able to give this evening, and I think it would be helpful to clarify what areas you're talking about. If it's to do with social work teams, agency levels, it's an easy answer. We have very few agency staff. We operate with permanent staff and recruitment. I think that's something we need to feed back separately because it's quite detailed, actually. Yeah, and we need to involve other departments.
Yeah, fair enough. Thank you for that. Okay. My final question, or one more after that. Performance targets. The report says assessment performance roses from around 41 to 57%. So what is the target, for example, 70%, 80%, 90%?
No, 65%. That's the target, 65%. And it's reset every year.
It's been improved from last year.
And it's an improvement, yeah, certainly the performance has gradually come up over the past year.
Sure. It seemed to be a pretty low, but we just don't want to go into discussion now because of the time, so we'll move forward. Would it be possible for us to, as a committee, to look at the data in, say, November time, and also the improvement plan? Can we have that something possible? So we can look in November time? Like it should give us enough time to get the feed and information you are going to have that. Okay. Right. Thank you for that, and apologies for quite a lot lengthy questions. Anybody got any comments? I suppose move on. Councillor Crofts.
Yeah, I'd just like to thank you and all the staff really for the efforts so far from the CQC inspection. I mean, we are where we are, but today, believe it or not, it's a bit of a coincidence. The CQC has published the overall local authority ratings, and there was 35% of 143 local authorities that were rated requires improvement. That's 50 local authorities, and we're one of those. There were 90 local authorities that were rated good or outstanding, and I wish we was in that good or outstanding bracket, but we're not. We are where we are. And there were 3 authorities that were rated inadequate, which is 2% of the 143. So it is really us as a committee being able to help the directorate and the portfolio holder about getting us into the good bracket. And I think data is coming up as one of the key points, that we need to get our data correct. And we've got a journey to get there and hopefully a timetable to do that. And Intelligent Eye will help us with that ongoing as well. The provision of liquid logic, I remember us changing over to liquid logic, and does that need to be reviewed? It's not a question for this evening, but ongoing, is that system fit for purpose in terms of what we need to record ongoing? So now we know what the CQC requirements are. And obviously we are on a journey of getting into the good. But this is only one aspect of the Section 50 letter that we were given, that is only given to local authorities that score an inadequate. It's not given to every local authority, as was mentioned in the meeting earlier. It's only local authorities that get an inadequate in an area that get a Section 50 letter from the Secretary of State, which we have got as a council. So that's why, as a committee, we want to focus on these inadequate areas, the first one being this evening of assessing needs. But yeah, I think, Chair, we need to timetable when the KPIs come out for Q1 of this year,
Sure.
April, May and June, just so we can compare them to Q4, if that's the data we've got at the moment. But I also think we need to programme in Intelligent Eye coming to this committee as well, and giving us an update of when the data is going to be ready for adult social care, so we've got more accurate data.
Thank you
But
so
no,
much
thank
for
you for all the work so far.
your comments. And
Thank you,
Councillor Ryder.
As usual, people get in before I can. Dean, as Dean said it, I was saying it just to say thank you to the staff. I know how hard they work, and I have every confidence that they will get us back to where we want to be. And I would support everything that Dean has just said and what we should be looking at. So that's really what I wanted to say, was thank you very much.
Thank you,
Thank
Councillor
you.
Ryder.
Very kind.
I would also echo what already my fellow councillors have said. Thank you for your hard work. Thank you for bringing this report, and thank you for having a patient be asking so many questions. So really appreciate your time and keeping us posted. So members, are therefore happy to note the steps being taken by the Adult Services Director within the involving improvement plan in relation to assessing need. Are we all happy with that?
Yeah, just one more comment, Chair.
Short one, please. Short one.
Just so the public are aware, assessing needs is the most difficult area that local authorities struggle to attain. There was only 23% of authorities got a good or outstanding in assessing needs. So we've discussed this evening the most difficult area of adult social care in England at the moment, because 78% of that 143 local authorities struggle with assessing people's needs. And that's quite pertinent in that we're not on our own on this journey of assessing need. We're one of 78% of authorities that struggle with it.
Thank you so much, and thank you for your valid comment. Are we all happy to? Sorry, do you want to come in, Kate? Or
No. I think we'll leave it. I think thank you for that, and it is important. It doesn't take away the work we've got to do, and we are doing, but we want to be in the position where we're very thorough and we're confident with that data, because the data is the area that was the area of focus around what is considered, whether it was right or wrong. That was the position we were in. So we're learning and we're pulling that together. And just going back to that point that was made around the core areas of the Section 50, that's why the high level improvement plan focused just on those. There's loads of other strands of work going on, but they are our top priority. We want to move on from the Section 50 and onto our normal plan as quickly as we can.
Thank you so much. So are the all members happy with the assessment? Yeah, are we all happy? Excellent, thank you very much. On behalf of the committee, may I thank the Chief Officer for Practice, Quality Standards and Strategy, Adult Services, for the report. Thank you very much. We appreciate that. We move on to agenda item number 6. There have no callings in, so we'll now move on to agenda item 7. Record of decisions of the executive. The committee is invited to note that there has not been a meeting of the executive since the last meeting of the committee. Therefore, no decisions falling within the remit of the committee have been made. Thank you. We'll move on to agenda item 8. Summary of relevant individual executives' decisions. The committee is invited to note that no decisions falling within the remit of the committee have been made since the committee's last meeting. Thank you. We will move on to agenda item 9. Notice of forthcoming decisions to be taken by the executive. The committee is invited to note that 2 decisions to be taken by the executive for the 4-month period from August to November 2026, which fall within the remit of the committee. The decisions relate to the adult services, customer feedback 2025-2026, and annual adults safeguarding report 2025 and 26. The annual adults safeguard reporting 2025-2026 will be considered by this committee in November 2026. And the adult services customer feedback 2025-26 is scheduled into the committee's work program for its meeting in March 2027. Are members therefore happy to note the 2 decisions? Are we all happy? Yeah. Thank you so much. Right, we move on to agenda item number 10, Committee Work Program 2026-27. The committee has before it its work program for 2026-27. Are there any further suggestions that members wish to note? Do we have any suggestions? Any? No? Right, thank you for that. When members have been, are members therefore happy to note the committee's work program for 2026-27? I believe we already said yes. Thank you. That concludes agenda item 10. Thank you all for your virtual attendance and contributions. There being no other items of the business, I declare this meeting closed. Thank you and have a lovely good evening. Thank you all. Apologies, we had quite a long one.
Thank you.
No worries. Thank you.
Thank you.
Take care.
Thank
Bye-bye.
you.
Bye. Bye. Bye.